Good evening, everyone, and welcome once more to this joint EUROGEN ERNICA webinar series. As Darren mentioned, my name is Sara Romano, and I am one of the project managers for ERNICA. Before I hand over to our speaker today, I would like to take the opportunity to tell you a little bit more about the European Reference Networks, or ERNs. So as the name indicates, the ERNs are networks of European hospitals and patient organizations that are working together to support patients with rare and complex diseases, as well as their families and healthcare professionals. They do this by pulling together expertise, knowledge, and resources from all across Europe. The European Reference Networks were established in 2017 by the European Commission. There are 24 of them, and each focuses on specific rare and/or complex disease area. So today, two of these European Reference Networks have teamed up to bring you this webinar, and these are EUROGEN, the European Reference Network for Rare and Complex Urogenital Conditions, and ERNICA, the European Reference Network for Rare Inherited and Congenital Anomalies. So today's webinar will be presented by Daniel Rossi, and Daniel is a PhD candidate in pediatric surgery and is also a project manager of the European Pediatric Surgical Audit, the EPSA ERNICA registry. He works both at the Sophia Kinderziekenhaus at the Erasmus MC and at the Department of Women's and Children's Health in Karolinska University Hospital. Daniel will introduce the first core quality indicator set for Hirschsprung's disease. Co-created by a team of 96 experts from across Europe, these indicators are designed to elevate the Hirschsprung's disease treatment process and quality of care standards. In this webinar, the results of the Delphi consensus study and the subsequent consensus meeting will be presented. And this innovative set will encourage the use of specific tools and indicators to enhance Hirschsprung's diseases registries, streamline care protocols, and drive continuous improvement across Europe's medical landscape. So we really hope that you will enjoy this webinar, and now I would like to pass the floor to Daniel. So Daniel, the floor is yours.
Thank you, Sara, for your great introduction. And thank you all for being here today and giving me the chance to introduce you to the first core quality indicator set for Hirschsprung's disease. The agenda of today is as follows. I will give you a brief introduction about the EPSA and quality indicators and about our project. Afterwards, I will tell you more about methods, the included indicators of the final set, how the consensus meeting went, and of course, we will conclude with the official first core quality indicator set and our future plans. First of all, I would like to introduce you to the concept of quality indicators for the ones that have not heard about it yet. Quality indicators are indexes that are used to measure a critical aspect of quality of care. They are used in a way that detects variation in the quality of care, and registering them should be feasible and consistent. In simple words, these indexes are indicators of quality of care that allows centers to compare their results with each other. Three types of indicators exist, which are structure, process, and outcome indicators, as you can see on the screen. Just to give you an example, a structure indicator, as you can see, is a physical and organizational characteristic, like, for example, the availability of a multidisciplinary team for specific conditions or volumes. So the number of patients that are treated with a specific condition in every center. Process indicators focus more on the care delivered to the patient. So, for example, if all patients that receive a specific type of surgery also underwent a full diagnostic screening before, and outcomes is quite straightforward. That's like outcomes that we register, for example, in research. To give an example about how quality indicators can be used to actually change care, I borrowed this graph from a colleague of the Dutch Institute of Clinical Auditing that promotes and works with the quality registration for esophageal cancer in the Netherlands. As you can see, the indicator that we're talking about is percentage of anastomotic leakages in esophageal cancer, and it has been registered in a tight span of more than 10 years. As you can see, in the last 10 to 12 years, the percentage of anastomotic leakages has gone from around 20% to around 10%, which is of course a great improvement. Using these indicators is crucial because you can actually use them to organize what we call feedback sessions, which is sessions in which one-on-one with the participating centers, you look at, for example, the best practice, and you try to converge clinical practice towards those standards. So that means that it also really has an important impact on care and well, clinical care in practice. The EPSA is also a registry of DICA. It stands for European Pediatric Surgical Audit, and it entails the participation of, at this moment, 30 hospitals. Those hospitals can compare their indicators on 7 conditions, which are Hirschsprung's disease, of course, esophageal atresia, gastroschisis, omphalocele, CDH, and rectal malformation. I should say this is only registered for the Dutch centers, because, as you all know, the European registration of this condition is done by our colleagues at EUROGEN, and since a couple of months also malrotation. I'd like to tell you a little bit more about the EPSA. So, as I said, EPSA has at the moment 30 participating centers from 17 different countries, and we have seen a huge rise in participation in the last 1 to 2 years, as you can see on the right. EPSA keeps on growing, and even though our final goal is to have all pediatric surgery hospitals of Europe participate, at the moment we are focusing for the next 4 to 6 months on connecting all ERNICA expert centers. That is of course a matter of funding, and we hope that in the future, with our new sustainability plans, we would be able to offer a place to everyone. If you haven't heard about the EPSA and you're interested, of course, please send me an email and we can get in touch. The goal of the EPSA is to improve quality of care. We do so by measuring quality indicators, and we allow benchmarking between centers of different countries. That means that every center registers their patients and can afterwards, with an updated platform every 1 or 2 weeks, compare how the aggregated scores of their centers are compared to other hospitals. The problem is that the indicators that we are using at the EPSA are outdated. They have been selected around 10 years ago by only a selected group of people, which were Dutch pediatric surgeons. And we believe that we can create new indicators which are selected in a methodologically sound way, that are internationally supported, and that can involve multiple stakeholders. So not only surgeons, but for example, also other specialists or patient representatives. So first of all, at the beginning of this presentation, I'm going to explain to you a little bit how our study looked like, and in the end, I will of course explain to you, tell you what our results were and how we think that the new core quality indicator set can be used in practice to, in the end, of course, make patients with Hirschsprung's disease better. How did we do it? The method we have used is as follows. We performed a systematic review of literature. You can find publication by scanning the QR code on the screen. In our systematic review, we included 200 publications of the last 10 years that were relevant for quality of care or clinical care for Hirschsprung's disease patients. We extracted baseline characteristics, care process characteristics, and potential quality indicators, which was, I can tell you, a very extensive list. We selected around 1,060 criteria in total. After this, we selected the top 5% items that were, or the items that were mentioned in more than 5% of the publications, and we combined that with the guideline recommendations from the ERNICA guidelines on rectal sigmoid Hirschsprung. Based on these, we created a long list of 21 baseline characteristics, 2 structure, 45 process, and 67 outcome indicators. We then invited the healthcare professionals and patient representatives to a 3-round Delphi study. We asked everyone to score every single item on a scale from 1 to 9, and in the last round to prioritize what the 10 most important indicators were for them. We presented them, of course, not only the indicator, but also help texts with definitions, timing of measurement, and additional information about the indicator, like numerator and denominator that are used to calculate it. And you can see that we had a very strict, specific inclusion criteria. At the end, we presented the results during a consensus meeting where 73 participants, out of which 4 patient representatives were present. Also here, we discussed the inclusion and exclusion of indicators that did not have consensus in both groups. I should have told as well that the 2 stakeholders, so the patient representatives and the healthcare professionals, were scoring items in 2 parallel Delphi rounds, and only after every round we would feed back to the other round, to the other stakeholder group, how they had scored the items. Let's move to a little bit of results already. First of all, I would like to tell you how the Delphi went. During the first round, 104 healthcare professionals and 10 patient representatives had filled in our survey. Already 24 indicators reached consensus in both groups. That is also the reason why already after the first round, we decided to, in the end of the study, to also organize a prioritization of items, because otherwise a core indicator set of, well, 24 items would have become a bit too much. In round 2, around 7 healthcare professionals failed to answer the survey, and 2 patient representatives, and 12 additional indicators were added to the pool of included indicators. Round 3 ended up, as you can see, 97 healthcare professionals and 8 patient representatives, so everyone that participated in round 2 also filled in their the third round. In the end, 39 indicators reached consensus in both groups, making it 2 structure indicators, 15 process indicators, and 22 outcome indicators. More specifically, I'd like to show you how the third round went, which is the one that led, of course, to the consensus meeting as well. From the 97 healthcare professionals, 59 hospitals from 17 countries were represented, which we are extremely happy with, of course. Italy was the country that was the most that represented the most centers, and that had the most participants, with 22. Important to mention that from the participants, around 88, so a big percentage of the total, were pediatric surgeons, but we were also able to have pediatricians, pediatric urologists, and researchers join this study. 52 out of 97, or well, in this case 96, because the last participants was not registered in these graphs yet, were male. When it comes to patient representatives, we had 8 patient representatives from 5 countries, representing 4 associations. Here, the majority were female. I'd like to use this opportunity to thank also the SOMA, the AFMA, and the Association of Hirschsprung's disease from the Netherlands for helping us create this core indicator set. So when it comes to the results of our Delphi study and the consensus meeting, first of all, as I said, we had 21 baseline characteristics in the beginning, out of which the indicators that you see on the screen now were selected to be implemented in the EPSA. Why do we need baseline characteristics for quality indicators? Well, you can imagine that when you're measuring quality of care, quite quickly you can fall into the discussion of, yeah, but we are performing worse, but we have more difficult patients to treat. Well, these items help us to create case mix models in the future, which will allow us to interpret a bit better the results of the indicators from all the participating centers. It's worth to mention that one baseline characteristic, which is neurologic anomalies, was selected by the doctors group, but excluded by the patient representatives. We have discussed this and presented a graph that you see on the screen, and decided in the end to well, follow the methodology and not include this as well. Now we move to the quality indicators. So this is a lot of text, which is also the reason why I decided to divide it a little bit throughout the presentation, but we will go through these items one by one. The most important thing to know is that we asked both groups to select the 10 most important indicators. In the end, we were able to analyze that from the two groups, there were 6 indicators that were common. These indicators were selected by both the doctors and the patient representatives, and were automatically included in the core indicator set. Of course, we discussed during the consensus meeting if we needed to adapt some well, definitions, but they were of course automatically included because of, well, they reached consensus already in the first place. So first of all, what is important for measuring quality of care is if a patient was treated by a multidisciplinary team. The definition for this was that Hirschsprung patient should be followed by at least 2 pediatric surgeons, a gastroenterologist. There must be pathological, radiological, and anesthetic expertise, pediatric and neonatal intensive care, specialized nursing, and psychosocial support at all times. We had a couple of comments during the consensus meeting that we didn't have the chance to implement yet. First of all, nutritional advice and physiotherapy was proposed to be measured at 5 years of age because of the fact that this was not implemented in the whole Delphi procedure. We will mention it in our publication, of course, but we will for now not include it in the indicator. And most importantly, how are we going to certificate a multidisciplinary team? Of course, this is something that ERNICA, together with EPSA, will in the future try to give answer to. Second indicator was the number of patients with Hirschsprung that were treated in a specific center, so a volume. Then we have 2 outcome indicators. The first one is percentage of patients that received a reoperation because of a Hirschsprung related complication. More specifically, if any type of reoperation was performed related to any Hirschsprung complication or complication related to its primary surgical treatment. This will be measured at 1 and 5 years after operation. Fecal incontinence at the age of 4 years. We proposed at the beginning of the Delphi to use the Rome 4 criteria, and we were expecting, well, not expecting, but we were foreseeing some discussion about this during the consensus meeting. But I can get from the 73 that participated actively during the consensus meeting, they all agreed to use the Rome 4 criteria to measure this indicator. I must highlight at the age of 4 years, of course, not before. Then we have 2 process indicators. The first one concerns follow-up, more specifically that every patient that has a confirmed diagnosis for Hirschsprung should receive follow-up at least every 6 or 12 months after the first year of life until transition of care to adult surgery. And the last indicator concerns intraoperative complications. So if any intraoperative complication was encountered, it must be registered, of course. We defined it as anesthesiology-related complications, surgical complications, or hemodynamic complications. And we will use the Karolinska criteria, which I will get back to in just a little bit. If you're more interested in the Klavinamandadi classification, of course, you can also scan the QR code. We have evaluated this to be the best validated tool to score and classify adverse events in pediatric surgery. Of course, every group had, because of the top 10 and six common quality indicators, every group had 4 indicators that was individually selected and that the other group did not agree on. If we start with the indicators that were included by the healthcare professionals, we have first the percentage of patients that present with residual aganglionosis. Residual aganglionosis as objectivized by histological proof. This indicator was discussed also with the patient representatives that were the stakeholder group, of course, that did not include the indicator, and everyone agreed to the inclusion of the indicator. I must say, during this session, of course, the indicators that were not agreed upon by the other group, we asked everyone to assess the validity and the significance of the indicator based on the graph that you see and on the comments of both groups. We simulated discussion, and in the end, we asked everyone to vote if they did not agree to the inclusion of a certain indicator. After this, as you will see later, we also asked if anyone thought that it was necessary to pool indicators together, which is also a possibility. The second indicator that the doctor selected was percentage of patients in which intraoperative biopsies were performed, specifically biopsies performed during continuity repair or at the time of creating a stoma. Also, this indicator was included in the final set. Third indicator was a percentage of patients that received regular follow-up during the first year of life. As you recall from my previous slides, an indicator that both groups agreed on was regular follow-up after the first year of life, and this concerns the first year of life. For that reason, we also proposed to pool the indicators together under the proposed indicator that you see here in bold. So percentage of patients receiving standardized adaptive follow-up care, patient support information, and the patient journey after diagnosis and or treatment. This definition, or like the wording of this indicator, came from the group in the consensus meeting. And also this was added. Last but not least, the healthcare professionals scored postoperative complications within 30 days as being relevant for the core indicator set. This included anastomotic complications, wound infections, anal excoriations, postoperative Hirschsprung associated enterocolitis, and more to be added. This indicator was pooled together with the intraoperative complications under perioperative complications. And that means that we will have, but you will see it later, big indicator with 2 sub-indicators that will be registered in the in the registry. We then move to the items that were selected only by the patient representatives. The patients deemed as important as from in the top 10 indicators receiving information about the availability of patient support organization and current guidelines. And as I showed you before, also this indicator was pulled together with the 2 follow-up indicators that we had on receiving standardized care, adaptive follow-up, etc., etc. based on this proposed indicator, we decided, or the group decided, to include. Next one is was a little bit a sensitive topic during the consensus meeting, because it's a percentage of Hirschsprung patients that experienced soiling. We proposed soiling as being an indicator, of course, based on literature that we had found, but according to the Krickenbeck classification. There was quite a lot of discussion regarding this, and more specifically, not really an agreement on the definition. We realized with the group that Krickenbeck is, of course, a classification and does not define the term soiling. So we decided to not include it as a quality indicator, but the proposal or the advice from the group is to register both incontinence and soiling in the following way: according to Krickenbeck classification at 1 year of age, and incontinence according to Rome 4 criteria at 4 years of age. But the quality indicator, so the index that will say something about quality of care, will only be focused on incontinence at 4 years. The next indicator was also a little bit difficult, and that's a percentage of patients that received definitive surgical repair, in which the anal canal was preserved. Specifically, the healthcare professionals, of course, commented that it's difficult to assess this objectively, since every surgeon performs a definitive pull-through with the goal of preserving the anal canal. On the other hand, we have had also some colleagues sharing some unwanted experiences with the patients that had, for example, in which the sphincters were not there anymore. So we have decided to indeed not include the quality indicator, but we will refer to the guidelines of ERNICA, which states, of course, that this is really important, and we will register it in the EPSA as well. More specifically, we will ask about anal prolapses with, for example, the absence of sphincters upon physical examination during follow-up. Last indicator that was included by the patients was that there must be a proper transition from pediatric care to adult care for Hirschsprung patients. And without too many discussions, this was, of course, included by us in the core quality indicator set as well. So hereby, I would like to present to you the more specific indicator set, the two structure indicators, the multidisciplinary team, and patient volumes. For the process indicators, we have a big indicator on standardized follow-up care and patient support information, which pulls together the three indicators that we have discussed before, that I've presented you before. Intraoperative biopsies. We did not include the preservation of the anal canal, and we did include, of course, the transition from pediatric to adult physician care. The most important outcomes are reoperation because of any Hirschsprung-related complication. Instead of any type of incontinence, in the end, we took only the first point, so fecal incontinence after the age of 4 years. And perioperative, so intra or early postoperative complications. Last but not least, the residual ganglionosis, of course. I tried to sum it up a little bit without too many words. So what you see on the screen now is what we propose, and we will use at the EPSA as well to make sure that we can improve quality of care for Hirschsprung's disease. So we go back to the EPSA. We have 30 hospitals that register their patients, and I think that the most important thing to realize is that we can use and we will use the core indicator set in clinical practice. The EPSA will have a new data set for registration of Hirschsprung patients that will include Of course, this quality indicator set, we will include also the NETS 1 HD core outcome set that has been developed some years ago, and the Clavin-Madadi classification for complications in pediatric surgery. I'd like to tell you something quite short about our future perspectives. I think that the most important thing to realize is that all quality indicator sets for the conditions that the rare conditions that we register are in the making, so to say. Esophageal atresia was finished a couple of, well, actually around a year ago. Hirschsprung's disease is the current presentation, and necrotizing enterocolitis has also been concluded. The rest of the conditions, so CDH, gastroschisis, omphalocele, and malrotation, with the addition of intestinal atresia for the future, they all have already a team that is working very hard, one team per condition, in order to have new quality indicators within the next year or two. So hopefully we will have the most recent and relevant indicators for all the conditions soon as well. All in all, and here I'm going to invite you also to the next study that we are going to perform. We realized that particularly during the building of the long list, when we had to select which definitions were the most relevant, that there is a big variation in definitions in medicine in general, but like specifically for pediatric surgery, it's not easy. So we decided to start with Hirschsprung associated enterocolitis because that was a very well, interesting discussion within the steering committee. We performed an ERNICA survey between centers that were in the steering committee, and we noticed that there is an incidence of HEC between 8 and 42%, which is of course it's a quite wide range. We know, of course, that there is pastoral criteria for classifying Hirschsprung associated enterocolitis, but we believe that as a clinical tool, this might either not be used, or it doesn't grasp what the clinical picture is of HEC. Therefore, we are organizing a study which is examining the definitions and diagnostic criteria of Hirschsprung's associated enterocolitis in clinical practice. We invite everyone to fill in a survey and to try to explain in their own words how the picture of enterocolitis is in their eyes. I'll leave this slide for a couple of seconds because I would like to invite all of you to scan and register yourselves to our next project, and yeah, I hope that many of you can be available and want to help us improve standardization and quality of care within Hirschsprung. I would like to thank first of all, René Wijnen, Thomas Wesser, Anne-Lof Grenstrom, and Pim Sloot for the supervision of this project, but also the great steering group that is behind the realization of this study, and most importantly, everyone that has taken care in the study in the first place, and all the participants. I would be very happy to see you again in our next efforts. So thank you all for listening, and I would be very happy to answer some questions.
Okay, thank you, Daniel. That's an excellent presentation. So we'll just give people a few moments to put in any questions. Just while we're waiting, just to, I guess, a reminder, if you think of questions later, or anybody watching this back on recording, you can also email me questions and I will pass them on to Daniel later. Also, a reminder to all the attendees that you will receive a survey at about an hour after this webinar finishes. If you could complete that, would be really helpful for us. We are about to do some analysis on all of our surveys from the past few months for all our surveys. So thank you very much for that in advance. Yeah, and we'll send out links directly to this video recording tomorrow. as well to all the registrants. So let's give it a few minutes for people to type in. Sometimes it takes a few minutes for people to type them. Okay, not got anything through, so that's fine. You know, so that does happen. So thank you, Daniel, for the presentation. Thank you. Yeah, no problem at all. And so thank you, everyone. Hope everyone has a good evening and the rest of the week, and we'll hopefully catch most of you again soon at a future webinar. Thank you very much, everybody. Have a good evening. Take care.